Okay, good afternoon, everyone. So following George Shiraus's it is always challenging. He's a fairly funny speaker. And then being in the same panel as Melissa Martin and George Shiraus, between us we have maybe a century worth of experience, and Melissa's only 29, so I guess that puts George and I in a kind of elevated age category. But just briefly about George, because I don't think I had ever really met him, even though we've been in the field for a long, long time. But I followed him into the Medical University of South Carolina, and I heard about him because we had a planning system there called Gratis, and I don't know how many people know Gratis, but that was a planning system that he wrote, and he actually made it available for free to the medical physics community. And a little bit after I arrived, I see George in an APM meeting, and he has a T-shirt of Yoda, and he had photoshopped his face on the T-shirt. But interesting fellow. So we're going to talk a little bit about building a radiation therapy clinic. But if you follow George, you have to have a joke. So René Descartes is sitting at a bar, and the bartender asks him, "Would you like another drink?" And René says, "Well, I don't think," and poof, he disappears. You get it? All right, I'm so glad because I was practicing this thing, and my wife, she's a dosimetrist, you want to see my joke? So I gave her this joke, and I thought it was just hilarious, right? And she's like, so she didn't think it was so funny. So let's put this into perspective. I don't have any conflicts of interest. I am going to mention a few vendors, but that's just because I'm familiar with them, not necessarily because I'm plugging for them. And Sam, I am. So let's put this talk into perspective. So there's a couple of messages here in the talk. One is that we're going to identify, when we talk about opening a center, we're going to talk about the key elements of that center. What is really important? So this presentation is going to summarize what we've done at the University of Maryland. And but another thing that I wanted to emphasize, and as Annie mentioned during the intro, this has been a fairly nice symposium today, the professional symposium, particularly because I like the fact that we're talking about leadership. And it's interesting that I put this in my talk, but so have so many of the other speakers. So it's really important that if there's a take-home message to this entire symposium, is the role of physics in the clinic. And I want you all to remember that as medical physicists, you are leaders in the clinic. You really, really are, just by virtue of your position. And if you take that responsibility seriously, the clinic is going to benefit from that effort. So just I'm going to be plugging this in throughout the talk. So if you Google medical physicist and then you click on images, these are some of the things that you see. You see science, math, engineering, computers, technology. You don't really see anything associated with leadership. Is that all that we are? Are we just techies? Well, sure, our traditional role is dose calculations and physics, brachytherapy, measurements. There was mention made of water tanks. This is blue water. It's not necessarily the wine tank that George talked about. But this is what traditionally is associated with medical physics, and then we expand our role a little bit. We have to work within teams, and we exercise oversight over planning, and we have roles in compliance. And compliance is more than just radiation safety. Compliance is also compliance with billing and Medicare regulations. So our role is expanded. So what is our role? So this is from the scope of medical physics. The document summarizes the tasks from which the medical physics is uniquely qualified. So what is uniquely qualified? Why does it say that in the scope of practice? Notice that our responsibility is to assure the safe and effective delivery of radiation. We're a key member of the staff, of the faculty staff of institutions. So why are we uniquely qualified? Well, we're uniquely qualified because we have problem-solving skills. We understand the technology, we know what it can do. More importantly, we know what it cannot do. And we can appreciate the perspective. So it makes sense for us to lead in the clinical scenario. And a quote that I often use from Bob Shalik and Gooden's book on medical physicists and malpractice is that how are we judged in our clinical practice? And we're judged to determine if we have been reasonable and prudent in our practice. So it's both reasonable and prudent for us to exercise this level of influence over the clinic. So that's our rationale. So let's just go ahead and move forward towards the talk. So I'm just going to describe to you my experience at the University of Maryland. So we're an extended practice. We have multiple sites over many counties, complex technology, many demands, shifting priorities. So that should sound familiar to all of you. This is what we do as a part of our jobs. I'm going to give you some perspective of the centers that we open. So we have 6 practice sites in 5 counties, 11 accelerators. We just opened a proton center. We have Gamma Knife. Gamma Pod is a stereotactic breast device that was designed by the physics team at the University of Maryland. We have brachytherapy at most sites. We treat roughly 250 patients or so system-wide. And we have about 70 faculty, and well over 200 staff in the department. And what I'm going to describe to you is a center in what we call an integrated practice. We try to make sure that our practice is standardized. We have clinical practice guidelines that are disease site specific. We have consolidated staffing. All of the staff report to the single department chair. We have centralized operational management and a single set of databases for our IT infrastructure. So this is the type of clinic that when we open a clinic, this is what we have in mind. So let's talk about opening this radiation therapy clinic. So as an overview, I'll have in an introduction, I'll just briefly talk about assumptions and goals. I'm going to spend some time on project management and design. There was a talk that was mentioned earlier this morning that addressed project management, and it's true that this is something that we need to be familiar with. Then I'm going to talk about the clinical program implementation after we've opened the clinic. So now what? What does the program need to look like? And then some closing remarks. So as an introduction, what are some of the assumptions? So we're going to assume that the clinical need exists, that there's a patient population that's going to be served by this radiotherapy clinic, that the necessary partnerships have been formed, that we have associations with the local hospitals, local physicians from which we're going to get referral, and then that there's financial viability and that has been properly evaluated. And I was very pleased to see this morning a pretty good talk about the pro forma and the importance of that when we're providing services. Another assumption is that the clinical requirements have been identified, and what I mean by clinical requirements is specific clinical requirements. What does the population, the patient population in the area look like? What are the needed services? What types of cancers are we going to treat? What type of conventional treatment or what type of external beam treatment what are we going to be providing? Are we going to have brachytherapy? Are we going to provide other services such as TBI, intracranial SRS, et cetera? Another assumption, or the last assumption I should say, is that this is going to be a standalone facility. So what seems to be happening throughout, and this makes sense from a patient perspective, is that patients want to be treated close to home. And patients also deserve the best quality care that they can get. So our assumption is that we're going to have a standalone facility that has all of the capabilities except for maybe a few, like Gamma Knife, for example. We can't expect every site to have a Gamma Knife. But most of the time, and for the majority of the patients, we can treat the patients at the community practice site close to where he or she lives. Then we have in-house CT, we have in-house staff and planning and record systems, and record and verify systems at each site. Our staffing, we have radiation oncologists and clinical staff, physics, dosimetrists, therapists. And the staffing models are going to depend upon the patient numbers and the practice complexity, and I'm going to give you an example here in a minute of the staffing at one of our sites. And we use guidance from ACR and ASTRO, et cetera. And ideally, the more staff, the better. But when you have more staff, you have increased operational costs, and we're at a point to where, given the reimbursement and the fiscal environment that exists right now in healthcare, we're going to have to be doing more with less. So there's a constant battle between quality and cost. So this is an example of one of our facilities. So this is the Kaufman Cancer Center in Harford County, north of Baltimore. So we have 2 accelerators, a Trillion TrueBeam. We have a Philips Brilliance CT, multi-slice CT with 4D capability. We have an electroflexitron HDR. Our planning systems are RayStation and Eclipse. And there's the staffing, and we staff for roughly around 50 patients a day. You'll note that there is a research coordinator on the bottom, and this is keeping in mind that there's this is an academic practice, so there's an expectation that we will treat patients on protocols, and we have quite a few protocols open and an expectation that patients will be enrolled on national protocols. So now let's move to the project itself. And opening a new clinic, and we'll start with project management because successful project management is key. There were some good slides this morning, and I'll try to complement the slides that were presented this morning with some of mine. So briefly, what's a project? So it's a temporary activity, and the idea is to produce a unique product. There's some good information by the Project Management Institute, and if you go to their website, there's quite a bit of information that's available for free, for download. A project is temporary, it has a defined beginning and end, and a project is unique, there's a singular goal. So clearly opening a new radiation therapy clinic is a project. There are different phases, or I'm going to call them components to a project. And the five components are initiation, planning, execution, monitoring, and closing. And I call them components because they're both phases of a project as well as groups of people that are performing the tasks that are part of that project. So this is a slide that I think complements one that was given this morning. And I'm going to take just a little bit of time to go over this. So think of each one of these components as either a group of people or a group of activities. So the initiation process group is these are the activities in which we decide that we're going to open the center. So we pretty much viability is established, and the general framework for what the clinic is going to look like is framed. Then immediately planning group starts at the same time, and notice that there's quite a bit of overlap between the initiation and the planning group. Once the planning gets going, then execution starts to take place. And this takes the most time. And all throughout the entire project, there's a monitoring team or a monitoring activity that just monitors the project. And then at the end, we just close the project to make sure that we've accomplished that singular goal of opening the center. So a little bit about complications in a project that I'd like to share with you all. So this is called the scope triangle. There are competing forces in any project. There's time, cost, and quality, and they all pull in different directions. There's something also called scope creep, and that is accumulation of new project functionality that you roll into the project that probably need not be there, and I'm going to show you an example of that in just a minute, a project that I was personally involved in that didn't go as well. It ended up okay, but it was a difficult project, and I'll show you why. And then more is not always better. The more people, and I think you can discern this in meetings, the more people that you have, the tougher it is to communicate and the harder it is for everybody to be pushing in the same direction or pulling in the same direction. So communication becomes extremely complex, and you're going to start to see me highlight or bold the word communication because it's going to come up often. So this is that project that I was telling you about. So a few years ago, we decided to implement a new planning system in our department. We implemented RayStation. So our initial project plan was to have these different groups of activities. So we had a group that was specifying the contract. What is it that we want to buy? What are the modules that we want to buy? How many licenses, etc. There was another project group that looked at beam data. Let's consolidate the beam data because now we have an opportunity to model RayStation. What type of beam data are we going to select for that? And then how do we do acceptance and test its functionality? What do we need to do for commissioning and training? How do we now train rarely large groups? We're moving an entire clinic to a new planning system. So what is it that we need to do? So the contract group, they went okay. It was a small, empowered group. These were the decision makers, the people that had the money. That worked well. Beam data became a project in itself. Trying to determine what beam data and the quality of beam data, this became a project by itself. This was very, very complicated. Acceptance went well because by then the beam data group had showed us that we really need to have a smaller group doing acceptance, and there were maybe 2 to 3 people that did that. The clinical release, that was our initial goal, but it was significantly delayed, months delayed, because of some of this scope creep. And training overwhelmed the project initially. As you can well imagine, trying to teach a brand new planning system to dosimetrists, to physicians, and trying to do this while at the same time maintaining the clinic ended up being tricky, to say the least. So let's go to the radiation therapy clinic design and development. So the first thing that I want to talk about is the project team. This is an extremely important group. It needs to be composed effectively. The project manager, we'll talk a little bit about that. This person is key, as you heard this morning. The project team is going to include a clinical team, and these are clinic staff. And by that I mean the physicians, nurses, patient care team, and the technical staff. And this is physics, dosimetry, therapy, etc. We have an administrative team, and these people are the ones that pay the bills. They're also the fiscal leaders of the project. And then, of course, we have architects, engineers, IT. Do not underestimate IT. And then the principal vendors. And one thing that we need to do often, I would offer, is brainstorm. And this picture may seem like a goofy thing to do, which is to paste little stickies on a board, but this has saved us many, many times. It's amazing how you think you've thought of everything and somebody comes up with something that you hadn't thought of. So we had multiple brainstorming sessions. It really, really works. So the project manager, and I would offer that the physicist doesn't necessarily have to be the project manager, and maybe the physicist should not be the project manager, but the physics needs to be very keenly tied to the project manager. Physics needs to know what's going on if this clinic is going to be successful in its opening. So the project manager identifies requirements, establishes objectives, directs the project pretty much from start to finish, and the project manager's role includes all of these things: administrator, facilitator, arbitrator, communicator. There's that word again. So why do I keep on saying that? because communication is key. I think it's the final frontier. I still struggle with communication, in spite of all of these years that I've been doing medical physics. And I think communication is even harder for physicists. And I'm going to show you in a minute why that is. But it's very important. You know, sometimes we have these great explanations that we think fully explain a concept, and what we get in return is something like, they don't have a clue what we're talking about. And that's because we didn't tailor what we were saying to the audience. So this is actually a pretty good book. It's called Brief, and I was surprised by some of these things. So the attention span really of an individual in a conversation is 8 seconds. My chair is more like 5. And I mean that in a good way. I mean, he's very busy, but I can see him glaze the moment that I start to go off on a tangent. So you really need to get to the point. So common mistakes that we make in communication is that we over-explain. And I bolded that because that's us. That's physics. We tend to over-explain. I don't think we under-prepare, but we over-explain. And sometimes we miss the point completely. We can go off on a tangent and miss the point completely. So this is really hard, effective communication. And I would offer that you get this. It's not a very expensive book. It's really light reading, and it's really worthwhile. Okay, so back to the task at hand. So this is how we pretty much organize the opening of our centers. We have a steering committee, and I'm going to go into a little bit more detail. And then we have these other subcommittees, and these are subcommittees of the main steering committee, and they all have their tasks. So facilities and engineering, we're assuming here that there's construction. And in most of our facilities, that's been the case. In most of our clinics, we've started out pretty much from the ground zero. And here we have local facilities, contractors, and then the vendor installers, the main installers of the main equipment. The clinic staff, this is the physicians, nursing, patient care staff. Physics dosimetry, self-explanatory, the therapy team. IT, again, don't underestimate IT. And IT, we have several, since we're in an integrated practice, we have radiation oncology, we have our own IT group. Local IT, the local hospital is going to have its own group. And then we have institution, University of Maryland IT, and we have to coordinate all of these systems. And then the front office, and I call front office things like medical records, billing and compliance, and staff of that nature. So the steering committee is the leadership group mostly, senior administration, medical direction, and then the section chiefs of each one of our sections, nursing, therapy, physics, etc. The project manager and the leadership of the subcommittees. Those constitute the steering committee. And the responsibility of the steering committee, or the main group, the one on top, was pretty much project management. We received subcommittee reports, maintain project timeline, documentation, etc., and act as a liaison. The facilities and engineering group, we have a senior administrator, facilities manager, and construction foreman. The vendor PMs, this is important. And I would offer that we have physics, clinic, and therapy representation. Responsibilities are as shown, architecture, design, construction, and then actually monitoring the construction. The clinic staff, this is physician leadership representation. Nursing is extremely important because they're the ones that know how to manage the clinic or the patients through the clinic. And this is something that we often underestimate. We don't understand that very well in physics, in my experience. So it's important to have clear representatives in this group. So they design the clinical space to secure the clinical equipment. They're in charge of making sure that clinical staff are trained and credentialed. And then they act as liaison between the center, physician groups, and the hospital. And they're also an integral part of the design of the electronic medical record, the EMR. Physics dosimetry, as you can well imagine, physics dosimetry It might be good to have radiation safety or regulatory representatives depending on your particular environment. So in our case, when we go to a hospital, there's an expectation that we'll participate in the hospital's radiation safety committee, so it's not a bad idea to have the local RSO as a part of this group, particularly if you're going to be doing brachytherapy at the hospital. And the responsibilities are as shown here, a lot of which was talked about in the prior talks, specifying the shielding, commissioning the machines, etc. Regulatory is a very important piece. Don't underestimate that. We've had projects delayed because we can't get a brachytherapy license, for instance, approved. And then physics and dosimetry training. The therapy team, they're in charge of the therapy space, so we pretty much the therapists are the ones that design the treatment rooms, design the console areas, determine immobilization devices that are going to be used, etc. They also participate in the EMR design to a great degree, and they're in charge of making sure that the therapists are trained in the equipment that they're going to be getting. Front office, this is also important. The composition of this team is administration, nursing, billing and compliance staff, IT for sure, and their responsibilities are as shown there. And then IT. So this is IT staff mostly, and there's administrative staff, physics, dosimetry, clinic staff. All of the other clinical groups, if you can want to call these down here clinical groups, should be part of the information systems subcommittee. And their responsibility is the things that our information systems group take care of. This is a very important team. This is a make or break. So to give you an example of some of the meetings of the coordinating committee at the Kaufman Cancer Center at Upper Chesapeake in Bel Air, Maryland. So this is kind of standard meeting agenda. This is what our standard agenda would look like. And then this is just a PDF of some of our meeting minutes to go through. So here you see, here's the physics and dosimetry task group that's reporting about our Eclipse, RayStation, the status of the trilogy, Calypso, license under state revision, still under state revision, still under state revision, CT scanner, etc., HDR license, front desk, nothing really here, IT, IEM, this is the interfaces group. We decided the challenge in this particular installation was getting interfaces going. And so we had a subgroup that was just doing interfaces. And this is interfaces to billing, interfaces for ADT, interfaces with the EMR, interfaces with, we use ARIA as our record and verify system. This was not an insignificant task. There was a medical oncology clinic attached to the radiation oncology clinic. They decided to purchase ARIA as well. So how do you tie all of these systems together? And then nursing, etc. So this is one of our smaller clinics. This is the most recent one that we opened in Cecil County, almost Pennsylvania-Delaware line. And so the clinic space is designed on the basis of the clinical need. And this is a relatively smaller clinic. We're expecting to see between 20 and 25 patients a day, so it's only one machine. But you can see, if you pay close attention, that it had physics involvement. So here's 2 physics offices and physics storage. When would you see that? Right? We have a place to put our tank. It didn't come easy, by the way. They're like, well, we could put a bathroom there. Yeah, it's like, yeah, you're right. But we really need a place to put this tank. So as the project develops, different people, and a lot of times the people in the planning group and the monitoring group are the same ones, and what you do is you change your hat. But just to kind of go through the process, so here are some of the members of individual teams, and then here are the phases. So as you can well imagine, during the initiation phase, the physician group and leadership are very highly involved in the initiation of the planning of the project, launching the project. And then once the planning phase starts out, now the leadership group is relatively low, but now administration, because it's starting to cost money, gets significantly involved, and so does the clinic and physics dosimetry teams. During execution, engineering is key. The rest are relatively moderate. In monitoring, administration keeps track of things. I would offer that physics does too. Make sure that your project is going along okay. And then at closing as well. So one thing that we've learned to do is to keep checklists, and I would offer that checklists are extremely important. I'll give you an example of some of the things that you can see on a checklist. So this is a checklist that we've developed over time. It's based on things that we've forgotten to do. And there's a lot of things that you need to take care of. Credentialing of physicians at the local hospitals. Liability insurance, RTOG. There was an expectation when we opened one of our centers that we would enroll a patient on an RTOG protocol. So we need to make sure that these things were done beforehand. Training. Health screening. Phones, pagers, uniforms, courier. Some of these things are local to us, virtual needs pantry. We have a lot of indigent care in the city of Baltimore. Parking, ID badges, linen. It goes on and on and on. EMR. And I haven't gotten to the physics checklist yet. ARIA data build. IT again. I would offer hire your IT staff a year before you open. Therapy. And then physics. Equipment list. MDE is the Maryland Department of the Environment. It's our regulatory agency. They're pretty strict. Quite a bit. So, checklist is very valuable. And then finalization at the end of the project. Let's bring it all together. And one thing that we do that has been extremely useful because we found problems at that very end is an end-to-end test. So take a virtual patient all the way through a process. If you have a phantom, do that. Register the phantom in the EMR. Try to get information from the electronic medical records of the hospital. Transfer billing information to your billing system. Then clinic space. Work a patient all the way through. Treatment plan the patient. Treatment delivery, deliver the fields. Try as many of the modalities as you can. And ensure dosimetry verification. Actually measure the dose that you think you gave based on the prescription that the physician gave you. So this is all extremely important. Do this before your first patient. The time to learn about the problems is not with your first patient. So now we open the center, so now what? So this is how we're organized, and again, remember that we're a reasonably large practice. So each site has an operational team, and each site has each members of each one of the specialties. So the operations run along this column, and there are members of each team on that particular operational group. But in order to attain standardization, we have this, I'm going to call it a matrix organization, where all of the physicians report to a medical director. There's a chief nurse, there's a chief of clinical physics, and there's a chief therapist, there's a chief dosimetrist as well. So the dosimetrist and physicist, et cetera, report this way, but for operational purposes on a day-to-day basis, the staff report to the operations manager this way. So I'll show you what our organizational structure looks like. So we have in the department what we call a clinical operations committee. And the clinical operations committee is the medical director and the chief of clinical physics co-chair that particular committee. We have all of the section chiefs that are as a part of that committee, so the chief therapist, chief dosimetrist, etc. We have the operations managers for each one of the sites are also members of that committee. And then this is a decision-making committee. If there's something that needs to be decided in terms of policy, that happens at this committee level. We have a series of advisory committees. We have a committee called Technology Steering. This is where new modalities are reviewed before they're introduced clinically. We have a Quality and Safety Review Council, a little bit about that in a minute. This is an extremely important committee. Billing and Compliance, IT Steering, and an EMR committee. So these are the advisement groups, and over here are the operations group. So each one of the centers has its own operational group. The divisions here are the individual divisions. So the physics division, the therapy division, those are the groups represented by these boxes here. Works pretty well, I think. Okay, some of the key committees are the clinical operations group. I just alluded to that, and that's pretty much the leadership of the department. There are key advisors from physics, therapy, nursing, etc., and they receive reports from the advisory committees for decision making. And another very important committee is the quality committee. This particular committee has quite a bit of power because this committee makes recommendations on quality and safety. So it's extremely hard to argue against that. So I would offer that we pay close attention to this. This is the committee that manages the Continued Quality Improvement Program. It also receives the safety reports. And a very useful document is the ACR Astro Practice Parameter Radiation Oncology 2014. That's a good document that you can use to form this particular committee. So, pretty much wrapping up. So, lessons learned, teamwork. I think it was one of the previous speakers mentioned that it takes a village. It really does. But remember the project pitfalls. You know, the bigger the group, the harder it is to communicate. Smaller groups is better. You want to make sure that we're all inclusive, so in general we try to include most people because we know that the project affects multiple peoples, but the bigger the group, the more ineffective the group. Murphy's Law, plan on it. Things are going to go wrong at the worst possible time. Just a rule of thumb, add 20%. If you think it's going to take this to do something, add 20%. Most of the time it works. But it can be done. And this is very rewarding when the center opens, when we treat the first patient, when everything goes well, when the patients are coming in. The local facility is very happy because now they have a center in their local neighborhood that they can go to. So we've done good, and we think that, and you'll do good as well when you do this. I'm not as concerned, I guess concerned, yes, but I'm not as doom and gloom about our financial picture. Because we've seen this happen before. There have been peaks and valleys in radiation oncology staffing, and there are times when physicists feel like, oh, they're going to be laid off, and then there are times where after we've reduced the force by attrition, that all of a sudden we find that we're understaffed, and then all of a sudden staffing goes back up. So hopefully this is one of those things. Now, given some of the changes that are going on right now, I'm not 100% sure, but I think that this is just something that's cyclical and it'll get better. So don't worry too much. So I want to acknowledge my colleagues at the University of Maryland that have helped me with this. And thank you very much for your attention. Plenty of time.
For a few questions.
You know, we don't get wine out there until 6 o'clock, so.
Kyle's got a question.
Dr. Prado, good,
Professor
great
Ankes.
presentation. Thank you. So one of the things we find is we'll ask to have the department heads come and serve on our committees, but it turns out the director of nursing has no idea how nursing actually operates day to day. And so she's just kind of guessing and throwing out spitballs. How do you find it, as a project manager, how can you get the right people at the table who are actually doing the work every day without stepping on the toes of the directors who may not be quite in touch with what's going on every day in the clinic?
That's a great question. So ideally, we would have in some of these working groups people that know what's going on the ground. And it's not uncommon that some of the section chiefs will ask other members of their team, they'll delegate the responsibility for the project to one of the working staff. We have had situations where exactly that happens, where we may have somebody representing a particular specialty that isn't 100% familiar with the inner workings of that particular group. So we ask that an additional staff member be identified. But that is kind of tricky, and it's happened. It's happened to us in physics. To be honest with you, I don't really know the intricacies of the day-to-day operations of the clinical physics group. So when there are times that I need that particular input, we delegate to another physicist to take that on. Okay. Well, thanks very much. Enjoy New Orleans. Don't get into trouble.